Thank you so much.
Hi, everyone. It's so nice to meet with you all today. I'm sorry that I can't actually see your faces, but I feel like, a talk like this about medications, within an hour, there's no way we could cover everything. So really, I want to make this interactive and for you to be able to ask questions. So please use the chat function. Um, in Zoom, and I will try to monitor that as we go and just continue to chat and throw in any questions at any time. And I'm also, trying to make it more interactive with using true false questions and stuff like that. So you can feel free to just, put that into the chat so that we can actually kind of interact, even though I can't see you. But thank you for joining me today. So I will share my screen, and I want to make sure all of you can see this, the slides. And since I can't see you, I can't be sure. I hope you
We
can all
can
see
see
it.
the slides. We can see the slides, Karen. Yeah.
Perfect. Excellent. Oh, I see someone's thumbs up. Thank you so much. Thanks for the introduction. I am Karen. I work as a clinical pharmacy specialist in Fraser Health. Officially, the title is Opioid Stewardship, but basically it's in pain management, and I try to make opioids safe within that. So that's what I've been. That's my position specifically. In my past, I have worked as a community pharmacist for a few years, and then mostly I've been a hospital pharmacist. I have no disclosures to tell you about, but I am receiving a speaker's fee from Pain BC for this activity for you today. And I just want to put a disclaimer in here that what we talk about today is more for information and for educational purposes. It's really not possible to make this an individual health advice type session. So if you do have any considerations about changing your medications, or if you have, individualized questions that need time and attention, you really should discuss that with your doctor or your pharmacist to make a treatment plan for you. So we'll start off with a true false question, and type in true or false or T or F into the chat. So is it true or false that chronic pain is best managed by medications? What do you think? So you can put in T or F, true or false.
You can also put a thumbs up for true and a thumbs down for false.
yeah, that can work too. And feel, safe to put in your, there's no judgment here. Someone raised their hand. Does raising the hand mean you have a question? I wonder.
Oh,
Maybe.
the chat is disabled. Hold on, I've got to enable the chat.
Ah, yes, that would help. Thank you. Ah, yes, chat is disabled. So somebody put it in the question and answer. Thank you. All right. Are you able to say, Anne, you can't raise your hands? Okay,
Yes,
I've got
sorry, I'm
two.
gonna troubleshoot this real quick.
Awesome. We'll let that be troubleshooted first. And this is nice that you can type in your questions in here as well as in the chat. I see two falses so far. Very very nice that you're able to put that into the question and answer. And those two answers are correct. So the answer here is false. Sounds like this audience is very knowledgeable already. Chronic pain is not best managed by medication. So although we're focusing on medications today, I just want to make it clear that medications are just one component, and medications are not the cure, especially when we're talking about chronic pain. Medications can work alongside Yeah, more falses. Thank you. More alongside, other management and therapies, and it may help to facilitate that, but it really isn't meant to be the main thing for you. So that's very important, because some people really think that, oh, as long as my medications are right, as long as I find the right thing, my chronic pain can be treated, or that it will be the answer. Overall, we have to say medications are disappointing for that. Many medications also might not work for people. For each medication, about some people may find a benefit, but some people may find no benefit whatsoever. And in general, we expect medications in chronic pain to provide about 30% of pain relief. Yeah, I see the comment from Andrew. Sorry, but it's not true or false. Sometimes in our pain journeys, it is best managed by pain meds. So I really appreciate that. Everybody is an individual. So that's very appreciated what you've said. I think what I mean is, overall, medications are not looked to be the answer. For some people, yes. And if it really works for you, that's amazing. Mostly it's meant to, and it's estimated to provide about a 30% pain relief. So if we think of that as just a component of pain management, it isn't thought to be the answer to your pain. So I've highlighted here the biopsychosocial model of pain. And thank you, Nicole, for your comment too, that you also find it about 30% effective. So, all of you joining Pain BC, I think, are very knowledgeable that, pain is not just about biology and anatomy, because I know Pain BC promotes this knowledge very well, and that pain is about all three components, and it is not just about the biological factors. It's also about the psychological and the social factors, and that highlights why medications are really just one tool in the toolbox. It's about everything else working together. So medications might help in the biological factors, and sometimes it can help with the psychological factors as well, in managing mood. But overall, it's meant to be part of other therapies, so that we can actually manage pain holistically and not just think of it as just a medical problem. So next question, and we'll try out the chat here. Is it true or false that finding the appropriate medication for your pain depends on the classification of your pain? Is it important that we actually know how to classify your pain in order to find the best medication for you? Yeah, Nicola's answer true. True from Susan. Thank you for lots of truths. Excellent. So that is a true. It's important that we actually learn to classify your pain, because pain is not all equal. So there's different ways of classifying. There's the acute pain, which is what you would normally see with injury or illness. Usually it lasts up to 3 months, unless you have continued injury to a site, for example. And that's so different from chronic pain, because acute pain is to protect us. We need acute pain to help us be alert of injury and protect ourselves, whereas chronic pain is truly not effective for us. It doesn't serve that evolutionary purpose to help us. So chronic pain and acute pain is very different. And that makes sense why then medications for acute pain generally are not very effective for chronic pain. So if we think of examples of acute pain, Tylenol or acetaminophen is probably the first to come to mind. It works great for acute pain. For chronic pain, very rarely do people find benefit with that. That's the same for opioids, like morphine. Works great for acute pain. Chronic pain is a different story. And that's why treating acute pain is so different from chronic pain, and why different medications are used. We also look at the pain features, so what type of pain you're experiencing. And again, it shows it helps to determine the kind of medications. So there's 3 main classifications based on the pain features. There's nociceptive pain, which is when you have actual or threatened damage to tissues. So that includes things like, an injury to a site where maybe you sprained an ankle, maybe you have a fracture. So there's actual damage to the site. There could be inflammation from that damage as well. And that's nociceptive pain. Whereas neuropathic pain is more to do with nerve pain. So there could be injury to the nerve or to the actual nervous system. So the nervous system is comprised of, our peripheral nerves, we have our brain, and also our spinal cord. All of that helps for these these pain signals to travel. So if there's injury or disease to that system, that's what we call neuropathic pain. So medications that work for nociceptive pain, so for example, again, acetaminophen or Tylenol, generally will not work for neuropathic pain because it's different. It's not actual tissue damage, it's the nervous system. And then thirdly, there's no, I typed that wrong, I'm sorry. That should be nociplastic pain. Nociplastic pain is different from nociceptive and neuropathic pain. And that nociceptive pain is pain that exists despite complete tissue healing. So that could mean a secondary source. So, you've had an injury and now you've completely healed, but you continue to have pain at that site. That's called nociplastic pain. Or it could be no identifiable cause. So things like fibromyalgia could fit into that, and that there's no damage, and there's no identifiable cause to that, and that can be part of nociplastic pain. Nociplastic pain is so different in that it can be more of a learned pain because there's no damage anymore. So if we use medications that treat, tissue damage or injury or disease, thank you. Yes, Karen asked, complex regional pain syndrome can fit under absolutely does fit under neuroplastic pain, and that this is something that your nervous system has learned. It's almost like the system has learned fear of movement, learned the horrific experience of pain, and now it's sensitized completely. And so the treatment of that is so different. And in nociplastic pain, medications often are not very effective for it, and we have to look into other management. So, overall, again, we're talking about medications, and so I just want to highlight the types of medications that are most commonly used. So if you look down this list, you'll probably find ones that you are aware of, maybe ones that you're taking yourself. So there's the non-opioids, things that we can even buy over the counter. So there's acetaminophen or Tylenol, and there's NSAIDs, and NSAIDs stand for non-steroidal anti-inflammatory drugs. So as you can see, it decreases inflammation, but it also decreases pain along with that. And there's ones that you can buy over the counter, like Advil or ibuprofen, but there are also prescription ones. There's the co-analgesics, and these are not opioids. So this includes tricyclic antidepressants, and we're going to go into this some more. Serotonin, norepinephrine reuptake inhibitors, gabapentinoids, other convulsants, skeletal muscle relaxants. Then the next big class is opioids, and then other medications that might help overall within that biopsychosocial model. So for example, sleep medications, because sleep is so important in pain. So sleep medications often fall under here, and mood medications as well. This is a complicated diagram, but I thought I'd put this here just so that you can see where pain medications work. When we feel pain, usually in the periphery, it sends up a signal over to our spinal cord, and then from there it sends a signal up to the brain, and that signal in the brain reaches many different areas of the brain. It's not just one area that feels pain. It's actually all connected, and it's very complex. The brain then sends more signals back down to the spinal cord. And when it's sending the signal down, it has an opportunity to either increase that pain or decrease that pain. And then that sensation goes back so that you feel the pain, and that all of this happens so instantaneously. And you can see that there are various places where medications can modulate that effect of the pain sensation. So the actual sense of pain is different from our experience of pain, because the damage to the tissue or damage to the nerves gets interpreted by the brain in different ways. And it's that interpretation and that sense of pain that we can use medications to try to change. So things like, for example, opioids can work at the level of the brain, but also at the level of modulation. And that's also where many of our co-analgesics work. So another diagram is here. So again, it shows this, what we call the, there's an ascending pathway. So I guess this is a better way to show that. So through the spinal cord, there's an ascending pathway up to the brain, and there's also the descending pathway from the brain back down. So there are medications that work on the ascending pathway to decrease that signal up to the brain, and there are also medications that work on the descending pathway to modulate that pain sensation. So you can see some examples of these drugs. So for example, the co-analgesics, like we'll talk about with the antidepressants. It's antidepressants is a misnomer because it works for more than just depression, but this is where it works, in that it helps to increase the descending inhibition of the pain signal from the brain back down to the spinal cord, and it changes that signal. And there are other drugs that work on peripheral sensitization, and that decreases the ascending signal from the spinal cord up to the brain. And then there are, again, more drugs that work on central sensitization, and there are other drugs as well. So you can see the various mechanisms. So it's not important for you to understand, the specifics of these mechanisms, but it shows how using different medications to target different pathways of pain can sometimes be a good way of having these medications work together to decrease that sense of pain. And it also shows that we're not fixing any problems here. We're really trying to dampen down that pain signal, because that's the main target in chronic pain, is we just want to calm down that nervous system. So, the first common drugs we'll address here are acetaminophen and NSAIDs, and that these are over the counter, although as I said, NSAIDs are also available through prescription. Acetaminophen, actually how it works is not completely clear, which is surprising when it's such a common drug, but it's believed to work through a central pathway via the central nervous system. And it is actually shown to be very effective in acute pain. And there are more and more studies that show in acute pain, acetaminophen or Tylenol is actually as efficient as, say, the stronger, what we previously believed as stronger painkillers like morphine. So it works really well in acute pain. But like I said, it only benefits some people with chronic pain. And that's it more rarely works for chronic pain. Overall, Tylenol or acetaminophen is very well tolerated. As long as we keep the doses below the maximum, you can usually avoid any problems with Tylenol or acetaminophen. But where the problems generally exist are that there are many combination products with acetaminophen in them. So There are a lot of accidental overdoses, and so that can cause problems for people. And I see a comment from Melissa that you've never had a good outcome from Tylenol and you haven't been able to tolerate it at any level. That's interesting. And, you know, again, for chronic pain, it's often very different. You're likely not to find so much benefit from it. I see a lot of people who tell me that they have side effects with acetaminophen, and sometimes when we dig into it, we find that actually it was caused by something else that they were taking at the same time. But you know, certainly any drug has side effects. So no drug has no side effects. So if you personally have some side effects with acetaminophen, I'd say you're an unlucky one. And I'm sorry about that, that you aren't able to use this very useful class of medications. And Melissa said, you know, Melissa has a lot of acute pain and it's still not working for you. And Rebecca said there's a stigma attached to Tylenol not working. And yeah, that's true. It's often, everything needs to be individualized. If there was one thing you're getting out of this, is that no medication works the same in anyone. Everyone reacts differently to medication. Some people are extra sensitive, have extra side effects, might not find a benefit, and other people will find a benefit, have no side effects. There's just a huge spectrum of what you can expect out of drugs. And that's why we have to try, and it's all a learning process. For NSAIDs, the most familiar ones probably are ibuprofen, which is Advil, and there's naproxen, which is also over the counter now, and there's diclofenac and many other NSAIDs as well. I would group Celebrex or celecoxib under this class as well. This class of drugs has an anti-inflammatory effect in that it brings down inflammation. So when we talk about nociceptive pain, like injury to the tissues, often that can cause inflammation, and the inflammation itself can sensitize nerves and make that area of pain even higher. So if there is nociceptive pain with inflammation, having a drug like NSAIDs is very helpful because it actually helps to bring down inflammation, while most of our other drugs just work more on the pain signal and not inflammation. And I see Nicola has said NSAIDs really bother your stomach, and Andrew has said it's helped you with migraines to some degree. So great point about it bothering your stomach. In fact, that's one of the most worrisome and most common adverse effect or side effect to this class of drugs, and that it can really irritate the stomach to the point where it can cause some very serious bleeding in the stomach. Now, many people can use it without harm, but if you have risk factors like a previous bleed, if you have reflux, sometimes even if you have no symptoms, but you're of older age, you're at higher risk of that happening. In some cases, we can give you a type of NSAID that is less damaging to the stomach, and or give you an extra drug that protects your stomach. But again, it all depends. NSAIDs can also harm the heart, liver, and there are kidney risks as well. So if we are using NSAIDs in a chronic manner or even in an acute manner, it's important to actually discuss that with your doctor or with your pharmacist so that they can assess your own risk factors before you use it for your pain. And I see Luva's question about medications that are effective for chronic pain. So here we are with co-analgesics. So these are drugs that are used primarily for chronic pain. These drugs are very rarely effective for acute pain because most of these take time to work. They're not drugs that work quickly, like, you know, acetaminophen, ibuprofen. You can take that and you quickly get benefits within an hour or so. These drugs can take weeks for you to notice a benefit. Although, for example, gabapentin can work much faster, and there are cases where you can use gabapentin in acute pain. But the three main classes that are best used for chronic pain that we understand the best and has shown the best efficacy are these three classes. So there's the tricyclic antidepressants, there's the serotonin reuptake inhibitors, and gabapentinoids. And we're going to go into each one of these. So as I said, tricyclic antidepressants, it's unfortunate that the name of the class includes the name antidepressants, because it sort of doesn't show that it has these other benefits in that it really helps for pain. And Cheryl has asked about cannabinoids, so I will address that later and we can talk about that some more. So tricyclic antidepressants include amitriptyline and nortriptyline. There's also doxepin, but doxepin is used more for sleep, not as much for pain, although it can also help for pain. And the way that this class works is that it increases what's called a neurotransmitter, or these are chemicals that work in the descending pathway. So from the brain back down to the spinal cord, it can help to dampen that pain signal. So when there are more of these neurotransmitters, specifically serotonin and norepinephrine, it actually helps to dampen that pain signal, which is so useful when we're talking about nerve pain, because that's exactly where that pain signal is traveling from, is through the nervous system, but also for chronic pain, because chronic pain is just a very sensitized nervous system. So that is why this class of drugs can be useful. And thank you, Andrew, about your comment about the latest research on cannabis, and that you're correct. He has a very good seminar. He has guidelines on that as well. And so back to tricyclic antidepressants. The pain effect is independent of the antidepressant effect, in that some people can find a benefit for pain, but not as an antidepressant. And some people will find that they benefit as an antidepressant, but not in pain. And some people may have neither, and some people may have both. So if you tried the class before for depression and it didn't work for you, doesn't mean that it won't work for pain, and same vice versa. So we have to try it more for pain. Pain dosing is generally lower than for depression. So usually at a lower dose, you will find benefit for pain, whereas as an antidepressant, you generally need even higher doses. This class of drugs is also used for sleep, and for sleep, it uses even lower doses. So for example, 10, 20, 25 milligrams is useful for sleep, whereas for pain, you need at least 75 milligrams, so about 75 up to 150 milligrams, whereas for depression, it can be between 100 and 300 milligrams. So you can see how the doses can be quite different. In terms of the benefits, this class of drugs is considered first-line treatment. So when we call something first line, it means these are the first drugs we should consider when we're treating neuropathic pain and fibromyalgia, because it's shown the most benefit and more consistent benefit. It also may improve sleep. So many people with pain have sleep issues because pain makes sleep worse, and sleep makes pain worse, or poor sleep makes pain worse. So for people with sleep issues, this might be a good class in that you might get a twofer out of it and have possibly better sleep and also have some pain benefits. The benefits usually take about 4 weeks to show, and you kind of have to climb up to that dose. So if you're 4 weeks, but you're really at a really low dose, you may not actually be experimenting with that drug sufficiently. You may need to actually go up to that target dose in order to find out if you have benefits. And that's hard. I see Melissa's comment about not finding benefits so far from antidepressants because the side effects are intolerable. So the side effects for people can be difficult. And that is why we start at a low dose, especially people who are extra sensitive. So people with fibromyalgia tend to be very sensitive to the side effects of drugs. And that's why we start at that low dose and gradually go up. And so if you imagine that very gradual process for these sensitive people, it can take quite a while. And if we've given up early, you may not have had that time to find out if that class of drugs work for you. And that can be so difficult because, yeah, like you said, even at the lowest dose, you cannot tolerate. So I've definitely seen that. So for example, in this class of drugs, it causes drowsiness, it makes you sleepy. It can cause some pronounced confusion and dizziness. Dry mouth can be so bothersome. It's constipating. It can cause difficulty urinating. It can cause people to have more falls because they're dizzy. And especially for people who are older, this class of drugs become more and more problematic in that we generally don't use it for people over 70 years old. And if you're, older, say, just before that age range, say you're in the 60s, we would still be very, very careful about this class of drugs because we know that you're getting to the age where you're going to have more and more of these side effects and that you're going to be more and more sensitive. So this class of drugs tend to be harder to tolerate. So it's great for younger folk. It's yet great for, if you've tried it and you were able to tolerate it, then that's great. But otherwise it can be difficult. So like Melissa said, if you've tried it and even at the lowest dose, you couldn't tolerate it, unfortunately, it means that this class of drugs may not be appropriate for you because the harms may be outweighing the benefits in this case. This class of drugs can also cause some sun sensitivity, and it can also cause some weight gain, about 5 to 10 pounds. But when the drugs are stopped, that weight gain usually goes away. The next class is called serotonin norepinephrine reuptake inhibitors, or SNRIs. These are also antidepressants, and the name of this class is really describing the mechanism of how this works. So examples in this class include duloxetine or Cymbalta. Duloxetine has actually been approved specifically for pain. So although this class of drugs often is called antidepressants as well, duloxetine is specifically indicated for pain. And venlafaxine or Effexor is the other example. As the name of the class says, it increases serotonin and norepinephrine. So that's the same as the tricyclic antidepressants. And these are the neurotransmitters or the chemicals that dampen that signal from the brain down to the spinal cord. And that helps to calm the nervous system and also helps for nervous system type pain, so neuropathic pain. And it also has been shown to improve mood. So both of these drugs work for depression, anxiety, panic disorders, so also for mood disorders. So again, like the other class, the pain relief effect is independent of antidepressants effect. In terms of the benefit, it's very similar in that it's first line for neuropathic pain. It's, as I said, duloxetine has a specific indication for low back pain and even for knee pain or osteoarthritic knee pain as well, and fibromyalgia. And most people will need time to notice that benefit. But interestingly, with duloxetine, it can work within 1 week, but still usually within 1 week, you may notice the start of some benefit, but you still need about 4 weeks. And the reason for that is you need to build up those levels of serotonin and norepinephrine. This isn't a class of drugs where all of a sudden you went from low levels of serotonin and norepinephrine to suddenly high levels, because if you did, you would have lots of side effects from that. So it gradually builds it up. So you need that time to build up those levels of these neurotransmitters in order to dampen that pain signal down. And with venlafaxine, we need to reach a target dose of above at least 150 milligrams a day to see those benefits. Whereas with duloxetine, even at the starting dose, it can start to have that benefit, which is why you can see that benefit earlier with duloxetine. The risks for this class include dizziness, sleepiness, and insomnia. So notice that these are two opposing risks, in that some people it makes them really sleepy, and some people they find it very stimulating, because as you can see, it increases norepinephrine, which is like adrenaline. So if you're more sensitive to that, you will find that if you take it at bedtime, it may keep you awake. So in those people, we would say take it in the morning so that by bedtime you can sleep. Whereas for people who find that it causes sleepiness, we would say take it at nighttime so that you can be more awake during the daytime and have less dizziness. Most pronounced at the beginning of starting these drugs are nausea and vomiting. Most people will have nausea, especially in the first few days, and which is why we need to start at a lower dose. Some people find it doesn't affect them, but I find that many people do have some nausea. And if that's the case, you can take it with some food, and also just low doses to keep trying. Sometimes we've even had to do every other day dosing just to start. And then as you build up the tolerance, that side effect tends to go away. So as you continue on, the nausea and vomiting side effect tends to go away. Most people just have nausea. I rarely see people who actually have vomiting with this, but nausea itself can be so uncomfortable. This class of drugs can also cause dry mouth, constipation. For people with any rhythm disorders with their heart, this class of drugs can be more dangerous for that. So everything is individualized, and that's why we have to look at all of you. And weight gain on these two also. Thank you. Yeah, weight gain is a side effect of most antidepressants. And yeah, so the third class of drugs are gabapentinoids. With gabapentinoids, the two main examples are gabapentin and pregabalin. And how it works is that it reduces the release of substances that that actually activate more of pain. So if we reduce that, it can reduce the ascending pathway of pain, and it just dampens down again the nervous system. So again, you can see why that is great for neuropathic pain or nerve type pain, and also chronic pain, because the goal is to dampen down the nervous system. I've put in here also the maximum effective dose, because the maximum effective dose for pain is actually different from the maximum dose that the manufacturer says. So for example, in gabapentin, the maximum dose that the manufacturer puts out is 3,600 milligrams. But evidence tells us that if we go above 1,800 milligrams, we get no additional benefit. We just get more harms. And that's why the maximum effective dose is actually lower. That's the same for pregabalin. It's 600 milligrams a day. So for people who are at doses above this, usually you will not find benefit, but you will experience even more harms from this drug. Again, this class is considered first line. So you can see all three of these classes are considered first line for neuropathic pain and fibromyalgia. And they may also reduce symptoms of anxiety, because gabapentinoids, as they dampen down the system, it actually also causes more sedating effects, and that can help people with anxiety. So that's a benefit, in that many chronic pain patients can have anxiety. And in terms of the risks, because it's sedating, it causes dizziness and drowsiness. It can cause some weight gain and leg swelling, and also some dry mouth. Yeah, and I see more comments about how it helps, but also the weight gain is problematic, right? So that's the gabapentinoids class. The next class I address are muscle relaxants. These are not considered first line, and often it's considered much further down the line in terms of effective therapy, but it can, so rarely would we ever just use a muscle relaxant. It would usually be that you try other drugs, and then if you need something extra, this might be considered like an adjunctive medication. And the reason for that is that muscle relaxants as a class is a misnomer in that muscle relaxants actually don't relax the muscles. What they do is they actually cause sedating effects more in the brain, and so as the brain decreases the stimulation, that can help give overall a relaxation effect. So as I said, they actually primarily work in the brain. So examples of muscle relaxants are methocarbamol, so that's available over the counter. So like Robaxin and many others like Robaxacet. There's so many different combination products with methocarbamol. And then through prescription, you can get baclofen, cyclobenzaprine, tizanidine, and as you can imagine, because this class of drugs work primarily in the brain, it causes a lot of drowsiness, a lot of dizziness, impaired cognitive function, falls. So that's again why it's not considered, higher up the line of drugs we would reach for, because it causes so many of these side effects. So these are drugs that can be more dangerous, especially when you're not so used to the effect. We would caution using this class of drugs with other sedating drugs. So for example, opioids, like morphine, hydromorphone, because then you're using two classes of drugs that are sedating. So then it can compound that effect, that harm. And also we try to avoid it in older people because they're more sensitive to that effect of sedation. We would say avoid driving or operating heavy machinery if you're on this class, avoid alcohol. And because it works on the brain, it can cause dependence and tolerance. So if you use this long term, you may find that it doesn't cause so much drowsiness anymore. You're more awake, but also because of that, it causes less of it's less effective. So really it's meant for short-term use. And in fact, with most of these drugs, there's not much long-term benefit that's ever been shown. Karen asked about pyramate, and I didn't address that here, but there are many other anticonvulsants, which is, so anticonvulsants are primarily used for seizure disorders, but many of these drugs have shown some benefit for chronic pain or specific pain types, because they also dampen that pain signal, and they tend to be more specific for certain types of pain, which is why I haven't addressed it in this talk here, because there are just so many drugs. So I didn't want to go into the specific ones, but topiramate would be under the class of anticonvulsants, and also it's to dampen that pain signal down. And Andrew has written that you take amitriptyline and recently cyclobenzaprine, and until now, neither your GP or your pharmacist suggested the risk associated with age, and you're turning 70 in February. So frustrating. I'm sorry for that. That is difficult. And, things get missed, and that's definitely, part of the reason why you're here today for some education, in that, sometimes as we age, you get more and more of these side effects as you age. And, you say you're turning 70, that's when people really start to notice that really dry mouth, and they have difficulty urinating. They feel more of the dizziness. So then that's when you start getting more harms than benefits. Everyone is different. So if you have no harms and you feel like you're benefiting really well from that, you may find that for you taking it is okay, but you would need careful monitoring. And other thing with amitriptyline and the combination of cyclobenzaprine is that the chemical structure of cyclobenzaprine is actually very similar to amitriptyline. So really, you're kind of taking two very similar drugs. And if you're not finding specific benefit out of cyclobenzaprine, because as we talked about with muscle relaxants, the way it works doesn't tend to give you any long-term side benefits, and it can cause some harms. So you're taking actually two drugs that can cause similar harms. And Karen has mentioned that topiramate helps to stop migraines, so that's great. It's not so much to stop migraines; it helps to prevent migraines. So for people who have, many migraines, having drugs that help to prevent migraines is necessary. So in that case, taking topiramate every day can help to decrease the number of migraines and also the severity of migraines. And in this talk, I haven't discussed migraines, but it does, because that's a whole other class of drugs, and it's quite a specific pain scenario. Here, I've really talked about very general terms for drugs. So here's another true false. So in the chat, you can type in if you think this is true or false. Every medication and every medication regimen should be personalized for your needs. True, Nicola said. True, true. Lots of truths. Yeah, you're all very educated in this bunch. True, that is very true. As we talked about, every one of us is different, and there's no way we can really predict what will work and what will not work, but we can make some educated guess based on what what you present with and what other disease states you might have. But what we screen sharing has stopped. Don't know what happened. The window has closed. Oh, I'm so sorry, everybody. Let me see if I can open this back up. I don't know what happened there. So we were talking about personalization. So, that's part of sometimes the frustration of finding that drug, and that we need to find, we don't know what exactly will work for you. And that's why with chronic pain, we have to keep looking to see, is this working? Is this not? If it's working, is it working well enough? So your regimen can be extremely different from someone else's, and everybody is different. So there's really no way to say one size fits all, because that's never true in pain. So if something works for you, it may or may not work for someone else. Okay, let's see how. Let me close this and share again. Okay. Now it's sharing in presenter mode. Let's see. Okay. I'm sorry, guys, for this. I've got. See, slideshow. Current slide, it's still in presenter mode. Okay, there you go. Great, you can see. Okay, perfect. Thanks for all these comments, everyone. And one approach with medications is called multimodal approach, or rational polypharmacy. Polypharmacy means when you are on multiple different drugs. And when we look at other disease states, so say like, heart disease, or, many other diseases, we want to try to limit the number of drugs to make it easier for you and to limit side effects and stuff. But with pain, it's actually different in that it's proposed that if we use multiple drugs, it can give you better efficacy because we're targeting different pathways of pain, but also it helps to allow us to keep each dose, each of the drug at lower doses. So that's what we call rational polypharmacy. In that you may see that you are on multiple drugs, and that is the reason to actually keep it more effective and also keep the risk of each drug lower. And that's the main aim of that. And that needs to be individualized for you, because if you find good enough benefit with one drug, you might not need the second or third or fourth drug. Whereas for people with very problematic management, they may need multiple different drugs. And that speaks to how we need to personalize. The next class of drugs I'll talk about is opioids. And I know that this class of drugs carries a lot of stigma, and if you've been affected by that, I am sorry about the stigma of this class of drugs. We understand that opioids for pain has definitely changed over the years, and that there was the time in the 80s and the 90s where it was really promoted as being excellent for pain, and prescribers were really wanting to use it to help patients with pain. But actually what we have learned is that opioids help great for acute pain, but not for chronic pain. In fact, the benefits of opioids for chronic pain are very questionable. Some people may find a benefit, and some people will find no benefit. So examples of opioids include codeine, fentanyl, hydromorphone, methadone, morphine, oxycodone, tramadol. It decreases the perception of pain, so it binds to mu receptors, and these receptors help to dampen that pain signal as well. So it's shown to be modestly effective for pain relief and function compared to placebo. Placebo means basically a sugar pill. So when we study drugs, we try to compare it to a sugar pill so that we can see, was there a difference? So it had shown very modest benefits compared to the sugar pill. But when we compare it to co-analgesics, so those three classes that I talked about earlier with the antidepressants and gabapentinoids, it actually showed the same efficacy, but there are more side effects with opioids. So that's important, right? Because in the past we thought opioids are so strong, so effective, but in all of these studies, it's shown actually the same efficacy, but with more harm. So you can see why opioids are not first line. And the long-term benefits are really unclear. Most of the studies on opioids were actually just for 3 to 6 months. And usually 3 to 6 months is when our body becomes tolerant to the drugs, so that at that same dose, you don't find that benefit anymore. So when you first start opioids, you might think, this is great, it's helping my pain. But in about 3 to 6 months, your body has developed tolerance, so that effect goes away and you need a higher and higher dose to keep the same benefits. And the problem with that is that as you increase the dose, side effects increase. So opioids for chronic pain are really a balancing measure, in that the benefits are proven in acute pain, palliative care, cancer-related pain, but there are unclear benefits of chronic pain beyond 3 to 6 months of use. That's not to say that there is no benefit, because some people will find that there is a benefit, and that talks again to the need to individualize pain management. And I see that Nicola has put in a comment about statements such as opioids are not overly effective for pain. Coding has chance of working. These statements result in us being treated. And yes, that's exactly what I mean, in that there's so much stigma, and it's so hard for a person with chronic pain who finds benefit with opioids to always feel like they have to defend themselves. But that's that's what I mean in that, everything needs to be individualized. So if you find a benefit, then it gives you a benefit. There's really, if somebody finds a benefit for chronic pain, I would advocate stay on the drug, and we would just keep monitoring to make sure that you are not experiencing harms, and that we always reassess this balance. The harms in chronic use are different from acute use. For acute use, you always hear it makes you sleepy, it makes you constipated. But for chronic use, it's different. It can affect memory, decision-making, attention, sleepiness, dizziness. It can slow breathing. So that's a problem for people who have, say, obstructive sleep apnea and other breathing conditions. It can increase falls. Over and over, it has consistently shown that opioids increases the risk of falls. And then because it weakens your bones and with osteoporosis, it increases your risk of fractures when you fall. So we see more older people coming in with fractures and falls, and we have to look to see whether opioids might actually be contributing to that. It can cause injuries. It can dampen the immune system, cause sexual dysfunction because it lowers your hormone levels. In men, it decreases testosterone. In women, it decreases estrogen. And there's the risk of overdose. So we can see that these harms are serious. And that's why we, look at opioids seriously, in that we really know that the harms can be very detrimental. And we always have to balance that with what benefits you're deriving from that. If you are using opioids, we also try to lower the risk by not using sedatives at the same time, because the combination increases the risk of slower brain function, cognitive impairment, falls, car accidents, overdose, drug-related deaths. And in fact, in people who use these combinations, so for example, if you're on, say, benzodiazepines, which is like lorazepam or Ativan, other sleep aids, that combination of use is associated with 5 times the increase of opioid-related overdose, of which the most serious effect from that is death. So we know that this combination is risky. And if you are on such a combination, this is where we, promote naloxone kits. And in that, naloxone kits can be something that can save your life, someone else's life. And naloxone kits, when I give it out, I say, we hope we'll just sit there and you'll never use it. And most likely you will never use it. But if you ever need to use it, it is a drug that can save your life. So if you think that you're someone who could benefit from naloxone, be sure to talk to your doctor or your pharmacist, and you can get this kit for free. So is this true or false? Natural remedies are safe. Cheryl has written, it's unfortunate that there is little support when discontinuing opioids. And Karen has written, you have to advocate for yourselves and find help. Opioid tapering is something that I am passionate about supporting. And I agree, you need someone who is knowledgeable and experienced in helping with that. Yes, I wish there were better support, and in the newer guidelines, that is the aim, is to provide more support for prescribers on how to help safely taper opioids. And Andrea said you were very surprised when your pharmacy gave you a naloxone kit and it just sits there, and that's perfect. We want it to just sit there. So don't worry about wasting it, but if in case anything should happen, that's there for you. So as you guys have said, this is false. Natural does not mean it's safe. There are many natural things that, promoted for many different disease states, including for pain. And that certainly does not mean that it is safer. In fact, if it's less regulated, it can mean that there are more harms. So, that's certainly one myth. So that brings me to cannabis, and that, cannabis is I believe, more and more used for pain. There are two types. So there's a synthetic type, and you can get that with a prescription. That's Nabilone, and it's synthetic THC. There's Dronabinol, but it's no longer available. And then there's the natural products. So there's the oral oils, the dried cannabis, extracted THC, CBD. So when we talk about cannabis, there's mainly two main compounds, or two main groups of compounds, THC and CBD, but there are actually hundreds of compounds within a cannabis plant. The two main ones for pain are THC and CBD. So, that itself can be a talk over an hour at least, but in that, there are some people, especially with neuropathic pain, that can benefit from cannabis. Now, we consider this more a third or fourth line treatment. So we would try to optimize everything else. And if you still can't get the pain relief that you need with drugs, cannabis can be something that you can try. In the evidence, it looks like if we try cannabis in 11 people, one person will find benefit. So, that number is not great. Most people will not find a benefit in pain. Many people tell me that it makes them sleepy, it calms them down, but the pain is similar. But the benefits are that, unlike opioids, it doesn't cause overdose, and it can benefit people with anxiety, stress, sleep. But there are risks of dependence, addiction. It can also impair concentration, coordination, balance, memory, judgment. There are many, many different side effects, and it can interact with many, many drugs. So if it's something that you're interested in, I would certainly try to talk to someone who's knowledgeable in cannabis. And there are lots of online resources, but I would choose trustworthy resources to look for this. And there are many different formulations, but for pain, usually I would recommend the oils, not the smoked root, because there are risks with that. For some people with very localized pain, the topical route can be beneficial as well. So we're nearing the end, because I know we're at 12:02 now. Is this true or false? If you need information about your medications, searching the internet is best. True or false? Yeah, Connie's written false. Susan said false. Many, many falses. Yes, the answer is false. I know many of us do this, so it's almost like impossible to say, oh, not search. But just be very careful when you do search, because the best thing is to talk with a pharmacist or your prescriber, so doctor, but a pharmacist is usually most knowledgeable about specifically the drugs. So if you have a community pharmacist that you trust well, that can be helpful. They can do medication reviews for you and set up appointments with you. There are also primary care clinical pharmacists. So there's a difference between dispensing pharmacists, say at your drugstore, versus clinical pharmacists who primarily look at the clinical aspects of drugs. And there are other clinical pharmacists outside of primary care. So if you're in a hospital, for example, there are clinical pharmacists who can help to look at your medications. That's the best resource, because like we said, everything needs to be individualized. So when you look up information on the internet, that's not personalized for you. And medication itself is so complicated that we need more personalized information. And I see that Marty's written about, what about low dose naltrexone? I didn't address that in this session, because again, it's very niche. Naltrexone is still actually very in more, I guess, experimental states, in that there's developing evidence, but not very strong. So it's actually not within most guidelines. It's often something that you've tried everything, and then you still can't find relief. And then that's when you start trying these other therapies. So that's why I haven't addressed it. And because it's so specific, I would really, you would really have to discuss that with a specialist who understands about naltrexone, to consider whether that might be right for you, and then to have a trial and see if that's right for you. So that speaks to the slide. Are your medications working for you? So as I said, we don't know whether something will work for you or not. And there are many people who will try a drug and find no benefit, but sometimes prescribers may forget to take that off. And we end up adding on more and more drugs. So for you, it's best to advocate for yourself by really being careful and monitoring. So to monitor if your pain, your function, and your enjoyment of life before and after that medication was started, how it has changed, because that will tell you if you should stay on the drug versus not stay on the drug, because, you know, it's always risk versus benefits. And if you're not getting the benefit that you need, then the risks of the medications may not be worth it. And we want to be able to take off drugs and not just try new drugs. So you want to be able to ask, like, when can I expect a benefit? So as we talked about, some of these drugs can take weeks to months for you to see that benefit. So you don't want to judge at week 2, it's not working, and then we stop it, and then we lose that opportunity of finding benefit. And you want to ask, what's the amount of pain relief you expect from that medication to make a real difference in your life? And that's a personalized question. That's not something that one person can answer for you. But what does it mean for you? You know, if that medication allows you to participate in more of your hobbies, that might be worth it for you. And, you know, versus if it makes some difference to your pain, but doesn't actually change your ability to do the things you want to do with it, you know, it might not be worth it for you. You also want to look at whether it's causing some side effects. I also wanted to address the question of dependence, tolerance, withdrawal, because I know many people often ask me about whether they are addicted to a drug. And, you know, there are issues with addiction with some drugs like opioids, and hence the stigma. But for most of these drugs, your body can develop dependence, but dependence is not addiction. So that's the same as if you were, you know, if you have diabetes and you need insulin, you're dependent on the insulin, but you're not addicted to insulin. So that's the same for these medications. Many of these medications, because it alters the neurotransmitters, alters your nervous system, you can be dependent on the drug, and so you can't suddenly stop it, but that doesn't mean addiction. And tolerance, with some medications, it can cause tolerance. So say opioids and the muscle relaxants, but in terms of those other 3 drugs, it doesn't tend to cause tolerance. So then you can use it long term. And then with withdrawal, that's when you suddenly stop a drug and then you have terrible effects with that. That's called withdrawal. Having withdrawal does not mean that you are addicted to that drug. So for example, if you're on an antidepressant, you suddenly stop it, you would have terrible experience with withdrawal, but that doesn't mean that you are addicted to that drug. That's the same with opioids. You can use opioids completely appropriately, be dependent and have some tolerance. And if you suddenly stop it, you would have withdrawal, but that does not mean that you are addicted to the opioids. I wanted to quickly mention adherence aids as well. You can ask your pharmacist about dosettes and blister packs, but if you're on multiple medications, adherence aids can be very helpful, and blister packs at most community pharmacies are free. And you can, if you prefer to make your own, you buy dosettes and do your own, but pharmacies will usually package your medications and blister packs for free. You can also download all sorts of different apps onto your phone and have alarms to help with meds. And here are some extra tips for staying safe with medications. Try to use only one prescriber if possible so that they know all the drugs that you're on. And if you do have different prescribers, just make sure that you have a list of your medications so that they can see what you're on. Notify prescribers of your medications, keep that list handy. So if you're ever in an emergency situation, people can see what you're on. You know, so for example, if you are, you know, say admitted to hospital and they can't find in a different province and they can't access what you're on, that list of current medications can help prevent you from withdrawing from drugs because they didn't know that you needed it. Follow instructions carefully. Don't mix opioids with alcohol or other drugs that make you sleepy. Store your drugs carefully, locked in a safe place. Keep track of when refills are needed so that you never experience withdrawal. I also wanted to highlight one resource for you. If you need clinical pharmacist support, you can self-refer to the UBC Pharmacist Clinic. It's completely free as long as you're a resident in BC. You can self-refer, or your prescriber can refer, but this is where you can get clinical pharmacy support to go through your medications, and they usually make an appointment of 30 minutes to 60 minutes with you, and they go through your medication regimens. And they help you to answer questions, and if they have any suggestions, they will write directly to your prescriber and help your prescriber to adjust your medications for you. And Kimberly has kindly put in the link there as well, so you will find that referral form. And that's the end, and I have gone over time, so thank you for sticking with me. Any questions that I have not addressed? So it says, I see a question about why has SSRI has been said to increase pain sensitization. That's not, I wouldn't say that that is true. So I don't know where that statement comes from, and I don't believe that that is true. SSRIs for some people may actually help with pain, but usually, so SSRIs increase serotonin, but it doesn't increase norepinephrine. And that's why drugs that increase norepinephrine as well as serotonin actually help with pain and decrease the sensation. So we have drugs that can do both, whereas SSRIs only increase serotonin, so it helps with mood, doesn't tend to help so much for pain, but it doesn't worsen the pain. So that's not true, that if it's prescribed for depression that people will have more pain. That's not true. But maybe what it can be is that if you are using it for depression, you can get a twofer effect if you switch to a drug that increases both serotonin and norepinephrine, so that you get a twofer effect. Whereas if you only use a drug that only worked on serotonin, you don't get the pain effects. So then maybe that's what they mean, that you end up having more pain. I see a question about neuroleptics. So that's more the anticonvulsants. And so gabapentinoids are a class that also fit in as an anticonvulsant, in that historically gabapentin was marketed for seizures, and then it was found not to be very effective for seizures. And then they found, hey, it's effective for pain. So that's why now it's primarily used more for pain. But there are other anticonvulsants that also help to dampen that signal. So somebody had talked about, I can't remember what it was now, another anticonvulsant, topiramate, I think. Yeah, so that's another example. So things like carbamazepine, for example, specifically has evidence for trigeminal neuralgia. Andrew has written about comments on persistent post-surgical pain. That's a very tricky area to treat, is chronic post-surgical pain. And there are people who have chronic post-surgical pain, and the best way to catch that is early on. And chronic post-surgical pain is likely that as you have caused damage to tissue or nerves, that we've completely revved up the nervous system. And so there are specific drugs that may target that like terrible revving up, and then causing that horrific chronic state that causes pain and inflammation far beyond the actual tissue damage. So there are specific drugs. So one example is if we can target NMDA receptors, that can help to stop this cycle. So drugs, for example, like ketamine, methadone, can help with that, especially more in the prevention piece. Drugs like clonidine, if you have that kind of pain, it certainly is something that's something that specialists can help mostly with. So you want somebody to be more knowledgeable with that type of pain in order to use these lesser well-known drugs to target it. And also, of course, as I said, drugs are not the only answer. So there are, many areas we want to look into. So I hope that helps to address your question about that, Andrew. Yeah, Joanne has said you have a client who uses lithium, and it's much more rare for pain, and there's less evidence, but there can be some chronic pain states where specialists may try it, especially if that person may have concomitant mood disorders, then they can get more of a twofer effect. It may, but it's certainly not a common drug for pain. Any other questions? Yes, Kimberly asked, may we share your slides with your attendees? Absolutely, and I will fix up that typo about the no-see plastic pain before we share. I'll stop sharing my screen. Yeah, I'm happy to share. It's hard to just share slides because, as you see, most of it was, discussion. So if you have any questions, like I said, it's best to really talk with a pharmacist or talk with your prescriber, or use that resource with the UBC Pharmacist Clinic. It's completely free, and they are clinical pharmacists who have had extra training in order to help you with that. Thank you so much for these comments. All right.